Okay, hi everyone. Glad to be here, being part of this amazing celebration, representing the Mission Thrombectomy Committee in LATAM. Here's my disclosures. And my topic today is about the Latin American perspective. And posteriorly, I would like to introduce a regional and a collaborative initiative in some slides. LATAM represents close to 10% of the global population, and we are part of the middle and low-income countries. Sadly, we really have ugly numbers with a significant superiority in terms of global burden disease. Middle and low in orange and high income in blue. You may see here the huge gap in terms of incidence, bad outcomes, and disability. Furthermore, we must face a significant disparities in stroke cost. Here is a recent publication in Lancet describing a variety of factors responsible of these situations. All these factors interacting each other like a vicious cycle, and finally resulting in poor outcomes. Today, we are here celebrating a decade of mechanical thrombectomy, but what about if we could have a time machine to see how powerful or not has been the progress during the last years? Firstly, we would find this review published in 2015, where the Chailas group highlighting the importance to implement a simple, affordable, and efficient strategies as soon as possible at that time, including clinical, structural, and financial ones, looking for a major stroke burden reduction. Honestly, we have made a progress in everything. Actually, we have a better tool for diagnostics. We have more and more information regarding stroke economics. Teamwork is possible, and definitely team has changed over the years. For sure, from the South America to North America, from one side to another extreme, and even our clinical tools have modified during the last decade. But what I consider the most impressive advance is related with our approach to the acute ischemic stroke. Moving from the medical therapies, including the IV thrombolysis, to the angio suite, and positioning this therapeutic approach as a true game changer, supported by the Big Five trials in 2015. However, in some stroke topics, this change and advance haven't been clearly, and it is frustrating, believe me. I'm really upset, a true nightmare, when we evidence that a lot of stroke patients in our region are receiving the same treatment as 1 decade ago or by far, knowing that the level of evidence is enormous in favor of mechanical thrombectomy and the revascularization techniques. So what's wrong? Here is a list of the main limitations identified in LATAM, including population awareness, powerless in the stroke care pathway, not enough data available, and the national stroke plans are not promoted with enthusiasm. Some strategies are being promoted and supported by different coalitions, societies, and organizations like Mission Thrombectomy, and committed to putting stroke on the forward and NCD agenda. Here, educational and research are highlighted because the results of this kind of trials have been so powerful that they have changed our clinical practice. Thanks to the research, we are currently treating patients in late window based on advanced imaging. But what about patients who arrive after 24 hours in a very, very late window? This is a common situation in LATAM. What would be the best approach for this kind of patients? And considering the perfect storm where advanced imaging is not available 24/7, how do we change the mindset of those colleagues and partners who are resistant and reluctant to doing anything without an MRI of perfusion study? Fortunately, as I mentioned before, things have changed on multiple levels. There is a trend today to back to the simple, even for imagings, seeking a pragmatic approach to treat the LVLs. And returning to the simple, to conclude today, I would like to briefly introduce an important project underway in our region, Here is the Done Simple trial, led by recognized friends of us, Santi, Tudor, Mark, who are considering a potential benefit for those patients treated after 24 hours, such as demonstrated in a previous series when the subgroups were analyzed. Functional independence and good outcomes can be achieved after 24 hours, and the treatment in a very late window have showed a comparative data in terms of safety and effectiveness. But the point to note here is that there is strong evidence showing that the advanced imaging may be not necessary for late window patients. The Done Simple trial is a randomized multicenter investigator initiative to evaluate the endovascular treatment in the superextended window. The primary endpoint, safety and efficacy of endovascular treatment up to 72 hours for those patients selected using an IEA solution, evaluating the DW-MRS at 90 days. The safety according to the presence or not of symptomatic hemorrhage or clinical worsening. The inclusion and exclusion criteria are very similar than other LBO trials. The LBO is confirmed using an IEA software, and patients up to 72 hours are allowed in the protocol. Here, the exclusion criteria. And the secondary endpoint, as you may see here, including the revascularization rate, the first pass effect, and some extras. And likely for the safety, the study may consider the final volume of infarct, and of course, all the serious adverse events and complications. Here is the flow chart, all the process supported by meetings and IA solution. This partnership with meetings was announced recently, just 3 weeks ago in News. And this solution is based on the processing of a plain CT scan and the fact that every hospital around the world has a CT scan available, but does not necessarily have the most advanced imaging available. Like other platforms, meetings works perfectly in your smartphone. The process begins upon receiving a notification, then you may integrate all the team. A couple of extra tools makes the solution helpful and really attractive. And at the end, the report may indicate if LBO is suspected or not with a fascinating viewer platform. Here are a couple of cases in our practice, detecting the classic M1 occlusion, but also with the capability to deal with a more complex situation like this inferior division occluded, but the CT angio didn't show it. And finally, the patient goes to the angio suite where the DSAs reveal a partially occluded of the inferior division of the M2 segment. A total of 500 cases are being considered, divided in 3 groups, and the interim analysis would be expected at different levels. Site selection and activation is planned in a stage, with a first period of time considering Mexico, Colombia, Argentina. In a second stage, adding some countries in Europe and Asia. Here is the information about the center selected and location. You may see here, Mexico, Argentina, Colombia, Spain, Romania, Bangladesh. And here is the timeline outlining the steps taken and the study forecast and evolution after a year of tedious paperwork. And finally, here we are. One more time, all the credits for the PIs and the rest of the team, highlighting the role of Jorge Cespedes from University of Iowa, who is the clinical manager of the trial. To conclude, some final message. Various stroke initiatives in Latin America are advancing and progressing. Probably 10 minutes is not enough time to mention them all, but believe me, we are constantly moving forward. Years ago, everything seemed to be moving in a slow motion, but let me repeat it. Things are changing, and Latin America is striving to do its best in stroke care. For the next decade, we want to exceed the expectations, following the mission to win the race against stroke. Here are some final messages from the SBIN and mission Thrombectomy to LATAM. Be open mind as neurointerventionalists. Believe and mechanical thrombectomy is the true game changer build a momentum, and finally join us with our philosophy and let's make history. Thank you so much. And here my team in Medellin, Colombia, I'm so proud of all of them. Thank you one more time.